Hi everyone, I'm Divya, the Chief Growth Officer for Qure AI. I'm here talking to Dr. Giovanni Lorenz today. Dr. Giovanni is a cardiac thoracic radiologist with over 18 years of work experience and has been a pioneer in reshaping the workflow for cardiac MRI. He's currently affiliated with DocPanel and conducts research at SOSHEC, USISH and UIW medical schools and residency programs. He previously served as a lieutenant colonel in the United States Air Force and a senior medical expert for the DoD. Dr. Giovanni Lorenz, welcome to RSNA. Have you been having a good conference?
So great, and like I said, usually I lose my voice by Wednesday afternoon, but I clearly lost it yesterday afternoon. So losing it by day 2, that means I'm having a great time.
Fantastic. You sound perfect already. I think we've had this conversation earlier. We're all still, I think, exploring the tip of the iceberg when it comes to use cases of AI in, this realm of healthcare, realm of radiology. But specifically in the outpatient setting, what do you see as some of the areas where technology and specifically AI could be really helpful?
Well, like I had said a couple different times, there's a clear demarcation between academic and outpatient environments. I mean, we all know that, right? Yeah. It's a different type of radiologist, it's a different type of technology. Yeah. And I had said this a couple times, and I think it caught on Twitter and a couple things, is that if you can make it in an outpatient setting, you can make it anywhere. It's the steel that sharpens the steel, right? Yeah. So with that comes with new challenges. We can't have AI that is boutique AI that only fits one instance. Right. That's only for that one radiologist or that one pipeline. Yeah. You have to have an AI and an AI platform and a complete understanding that meets the very, very critical demands that outpatient provides. Right. And I'm not talking about clinical critical demands. I'm talking about efficiency demands. Right. I'm talking about getting patient through this imaging center demands. Right. These things don't allow for boutique AI to just sort of flit and flitter, maybe work, maybe not work. Right. It cannot hallucinate in an outpatient environment. Yeah.
And you mentioned, there would be certain use cases or certain elements which are different in an outpatient settings. Could you maybe talk a little bit more about what would those be?
Yeah, so the way that I look at it for some of my outpatient centers, both in Department of Defense, outpatient centers that are for some of the major universities that have larger footprints regionally, is I start thinking, what is going to do either preventative or proscriptive screening sort of items? Yeah. And so they're very good, strong use cases, value-based and CPT code reimbursement for that type of AI. Right. So I think that's where we can really leverage the limited amount of fellowship trained radiologists in that area with having that AI partner. Yeah. And we talk about a co-pilot. Exactly. Co-pilot's a great idea. I like it that the AI sits there, it helps me, it potentially can even efficiency some of my workflow. Yeah. But at the end of the day, that co-pilot better be worth its salt. It better be making some money for me too in the outpatient environment. Yeah. So I'm gonna have it find a nodule, but it has to find a nodule quickly. Yeah. And if I have to do 5 more steps of click, 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 then that outpatient AI is not going to work, right?
Yeah, absolutely. And we've talked a little bit about the screening element, but do you also see a role for like incidental detections in the outpatient because there's such high volumes? Yeah.
Every radiologist in the outpatient is also a jack of all trades. Right. What that means is, although I'm a 17-year cardiothoracic radiologist, I'm going to do some pediatric stuff. I'm going to do some lower extremities, some MSK, and in there actually is enough peripheral arterial disease, vascular disease. I could see the thoracic aortic calcified, where I know I should be getting him into a coronary program, a lung cancer screening program, and so forth, based on the markers of what they say in the indication.
Yeah, and you are someone who has like the 17, 18 years of experience, but I'm assuming there are a lot more out there who are probably starting out and could do with a friend to help.
One of the big things we see, and we try to be very gentle in our peer review, is not everybody is here and here all the time. Exactly. In different areas, you can be here and then here and then here and then here, depending on the day, even. So if you have something that can help just keep a marginal level of baseline quality going throughout the experience for that radiologist and for that imaging center, then you got something that's actually worth purchasing.
Absolutely. I think in stroke care, there is the hub and spoke model, which has become quite common, but I think we have to actually bring it out also in chronic disease areas.
You know, the thing is it's sexy to talk about stroke, right?
Yeah.
We got this tight window,
Yeah.
we got to push, we got to worry, we
Yeah.
got to jump through things.
Yeah.
The cape is on, we're flying through the rescue, right?
Absolutely.
But the majority of patients don't fit that.
Yeah.
They're the ones who have spent their time, they waited,
Yeah.
they worked that 2 week to get in, to get the screening.
Yeah.
So you have a moment of to get that individual the best amount of care,
Yeah.
even though they're not screaming for help right then and there.
Yeah.
They actually are screaming for help.
Yeah.
We just have to take care of them the right way to get them that type of care that's opportunistic.
Yeah.
So if I'm doing a lung radiograph or a radiograph of the lumbar spine,
Yeah.
I can notice things that AI, particularly Qure's collection of AI,
Yeah.
and be able to provide that kind of additional opportunistic care.
Yeah, exactly. Yeah. Dr. Lorenz, you've been coming to RSNA for many years. Picture yourself 5 years from now. What do you want to see when you come back here in 2028?
I want AI to not just be a novelty, I want it to be a workflow component, such as the mouse, the keyboard, the dictaphone. When it's at that level, we know that adoption, acceptance, and now efficiency can now occur. Okay, right now it's too new, it's exciting, there's potential for purchase, but people are a little scared about it, right? I feel it's that same sort of scare feeling that people might have had with the mouse or the keyboard earlier in the day. So that's what I'm looking forward in 5 years to see that. Additionally, I want there to be so much growth in AI that we're not talking about only growth in the academic inpatient hospital system. I want AI to be so good that the value is proven in the outpatient setting. I want it to be so good that it's actually proven when you're in bed still, when you're at your home. That kind of AI is still possible and it's available to us. And hopefully in the next 5 years, it'll be really great.
Well, I hope so too, Dr. Lorenz, and thank you so much for the time you spent with us. And I think we can build this future together if clinicians and technology partners come together. Really, absolutely, really looking forward to it. Thank you so much. Yeah. Thank you.